So one of the papers that that I want to bring your attention that was published last year was actually my own paper. And I don't say that because I was the one that wrote it. I say that because it really tried to address one of the lingering questions that exists in blood flow restriction training implementation. And that is how to safely screen out candidates and what are the appropriate candidates to potentially engage in blood flow restriction training. And so this paper was actually born out of a collaboration with other instructors from competing, if you want to say that, organizations. Owens Recovery Science, big in the United States. Their founder, Johnny Owens, was actually one of the pioneers that brought BFR into the United States and really gave it a nice, strong roots. So we collaborated along with two other researchers on producing this manuscript that goes over some of the common barriers that exist after blood flow restriction training certification, because 3 of the 5 authors teach and field questions about some of the different challenges that exist following certification, of which the medical screening part is one of them. And that's what we're going to focus on in this update, because in the course, what we talked about was general tourniquet screening and what that means for potential risk. This paper sought to try to refine that screening process a little bit. And if we take a step back now and we talk about the whole safety screening process in and of itself, we first need to protect ourselves. Number one, we live in a very litigious society. So having a medical waiver and a release of liability form that has been commissioned for you by a lawyer, or for example, we included one in the bonus materials of the course, if you haven't checked that out already, should be a good first step. And especially when that waiver and release of liability has a lot of red light conditions. When they have red light conditions, we already know that we're not going to proceed forward with BFR, so it could be a good initial screening tool. And then after we have those individuals sign the medical waiver and release of liability form, we then want to engage, or at least have in our back pocket, a systematic screening procedure for each person that enters the door, right? And that is where the funnel and the screening algorithm come into play. And then after we even do that, we should have some appropriate pre-BFR training assessments that are physical examination procedures, whether that's taking blood pressure, heart rate, or looking for and attempting to do something like a capillary refill test. And then lastly, when we integrate BFR, in order to maximize safety, we need to make sure we're monitoring and adjusting our exercises, including our BFR related prescription variables, such as pressure and the application mode, whether it's continuous or intermittent, to accommodate for individual patient tolerances and their medical history. So with that being said, let's talk about the funnel. And now, when we got together to discuss this paper, which actually started in the midst of COVID, because I was creating the online course at the time, and I was getting all of these questions on social media and through DMs, et cetera, about what is the appropriate BFR candidate. And so that's where the funnel starts. The funnel starts out at the top levels, which are areas that we can provide substantial justification for the use of blood flow restriction training. And then as you get further and further down the funnel, that evidence, or at least the strength of evidence, decreases, because we don't know as much. And therefore, when you start out in the funnel, you see that the top ways to enter in terms of determining an appropriate BFR candidate is whether or not the individual has a loading problem or has a pain problem, right? So if an individual is intolerant to load, so for example, from a post-surgical precautions, like I had a patient the other day who could not lift more than 10 pounds. That is his post-surgical precautions. Well, if we're going to do a light load training, which he was cleared for, but but we all know that light load training takes forever in order to get to the level of exertion required in order to stimulate the mTOR pathway. Well, he's a perfect candidate to integrate blood flow restriction because he cannot lift heavy. Even though he wants to, he just can't from following a surgery. The loading problem also can include elderly adults. So they're, for whatever reason, like if they can't lift heavy for balance reasons, or even though, the evidence is pretty mixed, osteoporotic individuals where you might be a little bit more hesitant to introduce load, heavy lifting, that is, those are excellent candidates to fit into the loading problem. And then you have the other problem, which is a pain problem. You have individuals that have excessive amounts of pain, whether that's from a post-surgery, right? So post-surgery could be included in the loading problem as well as the pain problem. But then you also have those individuals that, for whatever reason, are still exhibiting some joint-related pain. Like, for example, following knee surgery, where they're 8, 9, 10 months, a year down the road, and they're still having issues with joint pain. BFR can be an excellent tool for that particular client to integrate into the plan of care in order to help get them to the next level and bridge that light load training to heavy load training that's pain-free, right? You can also have those individuals that are a little bit older, ex-athletes, and they have some joint pain. They can lift heavy, but then they realize that their joints get wrecked a couple of days later. BFR could be an excellent solution for those individuals that has been shown to be proved beneficial in improving not only muscle mass and strength, but also in function for those elderly, older individuals. So that's the entry point into the funnel itself. And then the next level, right, the next gradation of the funnel is clotting considerations, because we know that BFR has the potential to induce adverse events based on improper application, or in those individuals that may be more predisposed to having issues with their coagulation systems, whether that is pro-coagulation or they're reducing their fibrolytic, meaning their anti-clotting mechanisms, they're reducing that. So there are medical conditions that either reduce the anti-clotting mechanisms or increase the pro-clotting mechanisms. And when you have this imbalance between the two, that is a real concern when we're trying to integrate technology that might predispose them to symptomatic formation of clots. So this chart is what we designed in order to, again, try to take the BFR provider through pertinent thought processes that are relevant in order to get through this second gradation in the funnel. And so if you look on here, you start out with a thrombophilia. Well, what is a thrombophilia? A thrombophilia is any condition that can increase the likelihood of venous thromboembolism acquisition, or VTE, of which a DVT is one of those classifications. And VTEs are usually treated with anticoagulation medication, right? These can either be acquired or inherited, right? That's a big differentiation factor, which we didn't really get that much into in the paper. But in this respect, the entry point into this sort of algorithm is what we're talking about in inherited thrombophilias. So these are genetic conditions that individuals are born with that can predispose them to a heightened risk of getting a blood clot. Some examples are factor V Leiden, a protein C deficiency, protein S deficiency, prothrombin G2021-0A mutation, or a factor II mutation. And again, all of these either increase proclotting or decrease anti-clotting. So they switch the balance of the coagulation status of the blood. And thus, when they do that, there is an increased likelihood of a spontaneous blood clot. Now, whether or not that's actually symptomatic is a completely different story, but we need to be considerate when we're screening for the appropriate BFR candidate that we actually are asking these types of questions. And then how do we even further stratify? Well, we can use something called the Caprini, Caprini risk assessment and modified improved scale to help with stratifying the risk even further based on conditions. So this is a little bit, repurposed for for this webinar, but we published this as part of our screening process in our risk stratification paper that was published this year. That's going to be on the What's New in BFR update lecture next year. But this is open access, and this is something that you can look at if you're interested. But what this does is this describes different risk factors as different levels of points. So the more risk factors that you have in these different categories, the higher the risk of getting a DVT or a deep vein thrombosis, right? If you have more than 5, or more than 5 points, then it's a pretty significant risk factor. And the only thing I want you to notice in this here is we have in the 5-point category, we have elective major extremity arthroplasty, meaning total hip replacement, total knee replacement. Sometimes we could elect to use blood flow restriction in those individuals. They tend to be more deconditioned and the surgeries tend to be a lot more invasive, right? Both of those are going to contribute to increasing the risk of DVT formation. But with that being said, we know that there is strong indications for the use of BFR in this population. Thus, just because it has 5 points on this risk assessment factor, deeming it's a very high risk, doesn't necessarily mean that blood flow restriction is off the table. It just means that you need to collaborate with your referral sources to get on the same page to see if they have clearance for BFR. Now that list is pretty intensive, right? There's a lot going on that list. So what we wanted to also do is provide another more simplistic but validated tool that we can use to at least give us an idea of the level of risk associated with VTE or DVT acquisition. And this is what we call the modified improved scale. And all the modified improved scale is it's 7 factors that have been linked more so than not in the literature to an increased risk of having a blood clot. And then it's stratified according to point scale, right? 0 to 1 points is low risk, moderate risk is 2 to 3, high risk is 4+. And that leads it up to it in some degree clinician judgment. So it doesn't say that you're contraindicated to do BFR past a certain risk point. It just means that that individual is a little bit of a higher risk. So as I mentioned before, if you're interested in exploring safety screening from a paper that was just recently published this year, I refer you to Nascimento et al. In 2022 in Frontiers in Physiology. Returning back to this algorithm here, right? The next step is after you answer yes or no to does that individual have an inherited thrombophilia, we want to then look at does that individual have an acquired hypercoagulability? Now, if you look in the research, hypercoagulability and thrombophilia are generally the same thing, but hypercoagulability in this circumstance, we're talking about an acquired hypercoagulability. So like you can have an inherited thrombophilia that is classified as a hypercoagulable state because it's more likely to clot. But in our little flow sheet, we just differentiated it. We said inherited thrombophilia and acquired hypercoagulability. So hypercoagulability is one of 3 factors in Wirchow's triad, which is probably the definitive mechanistic explanation for the accumulation or the incident of determining whether or not that individual is going to clot, along with stasis and endothelial injury. right? Stasis means there's a lack of activity. Endothelial injury happens when there is damage to the vascular wall, and that endothelium now is unable to vasodilate and release these mediators that can help keep the blood flow going in the right direction. Well, when we're talking about acquired hypercoagulability, that is any condition that increases the likelihood that there is going to be blood clotting. And for our purposes, we want to focus on any recent immobilization and any other systemic conditions that might alter the circulatory system. For example, Paget-Schroeder syndrome, for example. But recent immobilization in the sense that if we go back to the chart, we go back to the chart here in the modified improved, you can see that there's 1 point for a complete immobilization, meaning bed rest, not being able to get up out of bed. That is one of the risk factors that we really want to consider, because that has been linked, especially with the more invasive the surgery, with higher onset of DVTs. Now, unfortunately, there really is no definitive guide as to whether or not, an individual will acquire a DVT based on any given circumstances. So it's really important for you to use clinical judgment and the knowledge of the pathoanatomy, the knowledge of the surgery, and the knowledge of the risk factors associated with acquisition of a DVT in order to make your decision. But even though we don't have definitive cutoffs, we can also utilize these pre-screening questionnaires like the Improved Scale or the Caprini screener to help encapsulate a partial picture of the diagnosis. And then after that, this is pretty self-explanatory, how after you answer the hypercoagulability, it's going to give you a recommendation, whether or not you should consult with the medical team or proceed with BFR training. And then we get to the third gradation, which is hemodynamic considerations. These are things in this thought process algorithm. These are things that we need to be more considerate of with respect to the individual exercising, and as well as their resting state of their cardiovascular and hemodynamic system. That means that it's important that we take heart rate and blood pressure prior to any initial BFR training, because we want to know how healthy their cardiovascular and hemodynamic system is. If they're excessively high in terms of their systolic, diastolic, or both, then we know that they're likely to have an increased risk of adverse events during exercise in general, but certainly during BFR. Does that make it contraindicated? Absolutely not. But we want to make sure that we're considering this in the screening process. So making sure we take heart rate and blood pressure beforehand. And then just like I said before, with no definitive guidelines on DVT risk, there's really no definitive guidelines with how exaggerated or how much our blood pressure can increase to determine a safe value. We really need to utilize our clinical judgment here. And it's important that, and I think this was, discussed in the online on-demand course, is that if we recognize that BFR has the potential to increase the blood pressure and heart rate response similar to, or potentially even exceeding in certain populations, high intensity training, then we should also be able to utilize high intensity training as a comparator method for, is this safe or not? Right? Now, other things to consider is that when we have individuals with comorbidities, such as those with diabetes, hypertension, individuals that are taking steroids, individuals with cardiovascular disease, or even those that are following surgery that have to be completely immobilized for a short to moderate term period of time, they're going to have altered hemodynamics. And we talked about it in the online on-demand course, which is that we have this exercise pressure response that we need to respect. The exercise pressure response is going to help us continue to perform exercise, but at a cost of increased exertion and discomfort. And those individuals that have comorbidities are going to be more likely to have exaggerated responses to exercise in general, much less blood flow restricted exercise. So we just need to be considerate of that fact and monitor blood pressure and heart rate before, by taking it resting, but also during the exercise. Whether or not you take it at the end of the first set, at the end of the second set, whatever, we highly recommend that you're taking blood pressure at least once during BFR exercise to monitor the potential for an exaggerated pressor response. Secondly, we recommend that on most individuals, particularly with individuals with comorbidities, that you're taking LOP each session. That becomes a lot more easy with automated technology, that you can get it done in 30 seconds and not have to whip out a Doppler. But if you are working with individuals that need to get their LOP taken and you only have a Doppler, we still recommend that at least for the period of time, at least 2 to 4 weeks, that of at least 3 to 4 sessions, that they're not showing exaggerated blood pressure heart rate responses, but they're also not increasing their blood pressure on a session by session basis, because that is something that we want to make sure that we're monitoring, even though the new evidence is suggesting that BFR induces a significant post-exercise hypotensive response that over time can actually reduce blood pressure in individuals with hypertension as well as normal tensive individuals. We still have to respect that, that's something that we need to monitor. Lastly, if you're doing any multi-joint exercises, which if you're a certified BFR provider from the BFR PROS, you're going to know that we rarely ever start individuals off with multi-joint exercises and rather focus more on isolation exercises. This is going to be even more important, that when you transition to a multi-joint exercise, hopefully it's either a stabilized exercise like a leg press, for example, that you don't have to worry about stabilizing as well as performing, then you monitor the blood pressure there. But generally speaking, that's important. These are the important hemodynamic and cardiovascular considerations to make in this gradation of the funnel. So people want guidance. And, I consulted with my colleagues over at Owens Recovery Science, and we came up with this algorithm that should help you understand when individuals are appropriate to perform BFR. And now let's start out at the left-hand portion of the screen, which is systolic blood pressure less than or equal to 139 and or the diastolic blood pressure less than or equal to 89. Well, after you've taken the blood pressure, you can document and inform your patients, and then you can hashtag chase the pump, right? Because those are all safe values. But on the other end, and the X should have come out, but whatever, we have greater than or equal to 180 systolic and or the diastolic of greater than 110. Now, that is high. Though on those end of the spectrum, you're not performing BFR. You're actually going to document and you're going to let the patient know, and then you're going to recheck it in 5 minutes. And then if you can't, and if you recheck it and it's the same level, then you're going to have to refer to the emergency department if you can't get a hold of their MD. And then the middle ground is where we field a ton of questions. And unfortunately, there's really not a concrete answer to this, but we're trying to provide some guidance here. So if those individuals are presenting to your clinic 140 to 179 or 90 over 109, right, and they don't have any symptoms, okay, that doesn't exclude them from BFR. We want to wait 5 minutes and recheck. If their blood pressure is still on the same level, you want to document and inform the patient as always, and then you can proceed to start with BFR training, but being extra vigilant. I will mention that with our recently published paper, we did classify as less than or equal to 160 millimeters of mercury systolic, and I believe less than 100 diastolic as being safe to perform BFR. But anything higher is a no-go. But on the other end, if those individuals are having symptoms, right, any sort of hypertensive related symptoms, you're not going to do BFR, you're going to contact the MD and you're going to move on. All right. So hopefully this little screening algorithm provides you all with some reference. And then we get to the fourth gradation of the funnel, which is physical activity considerations, right? This is going to be specific to the exercise history of that individual, right? We kind of came up with an arbitrary guideline of like 6 months, right? Has the individual exercised in any capacity over the last 6 months, and particularly resistance exercise? Because we know that with regular exercise, there is a repeated bout effect, and that repeated bout effect can protect you to some degree against the effects of ischemic exercise like under BFR. So I'd be less cautious about an individual who has a repeated history of training in a high metabolic stress type environment, because that is going to be a strong stimulus with BFR exercise. So for example, those triathletes are individuals that I'm not really as concerned because they're pushing their lactate threshold a considerable amount. So they're very comfortable with their ability to buffer some of that calcium ion exchange that's going to happen with repeated muscle contraction. But those individuals that are like 70, 75 that are not active, those would be the individuals that I'd be way more cautious of, but not exclude them from BFR. So really just important things to consider. And then last, the major surgeries, right? Have they had any major surgery or complete immobilization for longer than a week? Any recent long flights? These are all risk factors for DVT acquisition. And we have no idea how much of a risk it increases, but we just need to know that in the back of our head, hey, this is going to potentially be a higher risk than other things. So that's why it's important in the screening process to kind of think about these things. And this is just an old individual, total knee replacement, performing repeated straight leg raises with BFR. And then as we're entering the last couple of gradations in our funnel, it really gets down to some more theoretical things that we need to consider, particularly with respect to the additional medical history. So as I mentioned, or in the on-demand online course, that we need to be very familiar with what are the yellow lights and what are the red lights. We also need to remember that these are general tourniquet guidelines. Blood flow restriction is using a tourniquet-like device that will restrict arterial flow and completely occlude venous return. But it is not a tourniquet in the sense that individuals, except for when they're doing ischemic pre or post conditioning or cell swelling, are going to be applying a high amount of pressure for a longer period of time. Typically, exercise bouts last anywhere from 5 to 10 minutes with resistance training, and they're not under a very high amount of pressure for 45 minutes to an hour in their actual surgery. Like there are in their actual surgery. So it's really, right now everybody is tiptoeing around the fact that they're probably not the same, but we do need to understand that there is an additional heightened risk for those individuals that exhibit yellow or yellow flags, and certainly preclude those individuals that have red flags from training with BFR. All right. We need to also consider that in the first 6 weeks following surgery, DVT risk is at its highest, right? 100x in the first 6 weeks of acquiring a DVT. We know that with incidence of DVT, the symptomatic incidence is very, very, very low in the population. So even 100x that, you're still going to get a significant elevation in the potential for a DVT formation. With that being said, following surgery, we want to make sure that we're doing all that we can to screen out the individuals following their surgery, to make sure that if we're going to integrate BFR, we're doing it in a very controlled manner. So we want to make sure that on our physical exam, we're looking at the incision, right? We should be doing this anyways, but we're looking at the incision, we're assessing its healing status, and then we're taking in that whole picture with respect to the entire medical history in order to come up with whether or not a BFR might be appropriate for that person at that particular point. And then last, we're going to talk about consulting other experts or MDs, right? This is the last little bit of funnel. So if you are still cautious and don't really understand or know what the outcome is, meaning, are you able to do BFR with this person? Well, then the last step would be to consult experts or the referring physician. Because in general, I don't care 10, 15, 20 years down the line, it's going to be impossible for us to know all of the relative risk factors for all the different medical conditions, particularly the rare ones. So if you're having any issues in determining whether or not the individual is appropriate for BFR, just ask somebody. Ask a clinician expert, someone that has been using BFR in a similar type of population, or their referring physician, in order to get them on board in order to get the clearance to do BFR. All right. At the end of the day, you need to use your clinical judgment in determining whether or not an individual is appropriate for BFR training, and that's on you. So we're trying to provide some guidelines for you, but at the end of the day, unfortunately, the science right now, and the science where it will be in 20 years is still not going to be advanced enough to know absolute risk. We only need to know, we only should know what are risk factors that increase the likelihood of an adverse event with BFR, whether that's clotting, whether that's muscle damage, etc., and whether or not that individual can, the BFR intervention can be modified accordingly. And if you feel that BFR can be modified accordingly, right, you can integrate it continuously, intermittently, using autoregulation, not autoregulation, right? There are other factors that you can do that are BFR specific in order to come up with a prescription that can be safe for the patient, but also accelerate their recovery and rehabilitation. And then last, you want to end up with a physical exam, right? In here, I'm just looking over the client's leg. I am just trying to see, is there any varicosities? Is there any anything crazy that's going on in the lower extremity? That is, if imagining this is his post-surgical side that he could do. Here, I'm doing a quick diagnostic test called the Homan sign. This is just something that if you do a quick rapid dorsiflexion on the ankle, that's going to elicit a pain response. That can be diagnostic for at least referral to another provider to get a diagnostic ultrasound. Now, that was the summary of the perceived barriers paper, with particular emphasis on the safety screening.